Hello there and welcome back. This is part 2 of ill-defined radiolucencies, or how to identify malignancies in oral radiology. This video is going to cover squamous cell carcinoma, fibrosarcoma, and metastases. So I'll get right to it.
All right, we said the first one we're going to talk about is this, squamous cell carcinoma, as it's the most common malignancy of the oral cavity. Typically going to be a soft tissue tumor, but radiographically we're worried about it because it can't extend into the bone. And so this is likely a soft tissue tumor, and they do tend to arise in extraction sites. So if you have a non-healing extraction site, be wary of this. So very ill-defined, blended border, perfect candidate for a potential malignancy. This one has more of a well-defined but that ragged border. We have a little spindle of trabeculation left. So could it be an osteomyelitis? Sure, especially with these sclerotic borders where it looks kind of smooth and sclerotic, you might be thinking more infection. But just the ill-defined nature of this and the way it's so destructive, starting to leave that tooth floating in air appearance, be worried about a malignancy. Okay, what is the big worrisome thing in the panoramic radiograph here? Look for the anatomical structures. Hopefully you've watched my lecture on interpreting panoramic radiographs and you recognize all these different anatomical structures, especially the sinus floor and the zygomatic process of the maxilla. And you notice that one of those is missing here. There's no sinus floor. The maxillary bone over here is completely missing. You don't really see where it starts or stops. We've got this tooth floating in air here. The arrow is pointing to a little extent of the soft tissue tumor. So if you looked in this patient's mouth, it would be pretty apparent that something gnarly was going on. And so this is some type of soft tissue tumor that's completely destroyed the bone here. When you see that, be worried about malignancy. Have that on your radar, on your differential. This shows a cone beam CT. These are all three of the same case, just an axial slice. So the horizontal slice through the mandible, as we see, the posterior part of the mandibular ramus here. It looks well defined, but it does have that ragged border. So have that raise alarms in your head that this could be malignancy. Same thing in the coronal plane, and then in the panoramic radiograph. Yeah, I would argue this is well defined, but the way it's so ragged, leaving behind those little spindles of trabeculation. Contrast that with your typical cyst and benign tumor that should have a smooth corticated border on it. An exception to that is a cyst or benign tumor. They can become infected, and that infection, those infective byproducts can resorb the bone around the lesion and maybe leave a ragged or ill-defined border. Usually it's not all the way around the lesion like this. And so you really should start thinking malignancy when you see that much of the lesion that has ill-defined borders or ragged borders. Okay, here we have a case. In both of these, A and B, it may be tough to distinguish from periodontitis. But what do you look for when you're looking for osteomyelitis, which I stated earlier, is typically in osteomyelitis you have some degree of chronicity, some degree where the bone has laid down more bone. We know that periodontitis is typically a chronic disease, so if they have a periodontal lesion, usually have that smooth sclerotic border around it. These to some degree look well defined, but then you look closely at the border and there is this narrow area of an ill-defined border. Little bits of trabeculation where they're just starting to fade. And so you don't see that sclerosis around it. This one really doesn't look like a typical acute periodontal lesion. It's just too destructive and round to be something like that. And so yeah, they can be difficult to distinguish from just a periodontitis, an acute localized periodontitis, but do have it on your radar, especially when you see something this destructive and something that lacks those smooth sclerotic borders. This one, though, I think is pretty clear cut, where the first thing on your differential for C and D looks like the same case here, should be a malignancy. And why is that? Why not just infection? Well, if it's infection, where do you commonly get infection? Does it look like a typical periodontal or periapical infection? No, it doesn't really look like it's coming from the root of any of these teeth. Does it look like a periodontal infection? No, it doesn't really look like it's coming from the periodontal space either. This looks like it's arising from within bone, and then it has somewhat of an ill-defined blended border. It's starting to invade into marrow spaces, and then what's the key sign here around the roots of the teeth? See that little radiolucent haloing? We said malignancies really like to follow that path of least resistance. They extend into the apices or into the PDL spaces of teeth and destroy the lamina dura around it. Somewhat of an irregular PDL space widening appearance. But that is a strong indicator of malignancy, even over a potential acute osteomyelitis. Some more cases. This is similar to cases over here where it could just be periodontal disease, a very severe periodontal disease, yeah. But look for signs of infection. I don't see that smooth sclerotic border. I see teeth floating in air. Doesn't look like your typical periodontal disease, and you're going to be really wary of a malignancy. That's not to say that there isn't concurrent periodontal disease. In fact, they've got bone loss all around here. And this is a good example of that. Large triangle of calculus here. Obvious periodontal lesion, looks like a perioendo lesion. It's involved the apices of the teeth. This one does have a smooth border. That's what I'm talking about with looking for infection, seeing some degree of a smooth sclerotic border around it. But then over here we have tooth floating in air. We have more of an ill-defined, no sclerotic border around it. And that's really worrisome for a malignancy. All right, in C, we have somewhat irregular widening of this canal. Now I don't have right here, but you want to compare maybe in your mind's eye to a well-defined benign type of lesion that expands the canal. And it has more smooth, maybe rolling borders. Hemangioma is known to create a serpentine shape to the inferior alveolar canal, but typically it maintains nice, smoothly corticated borders. This, in some areas, it looks corticated, but in most of it, it looks like that cortex is destroyed and it leaves behind this irregular pattern. And so that's a sign of perineural spread of a malignancy. This one, a little tricky. So here we have a cone beam CT, looks like a sagittal slice. So like it's sliced vertically and like you're looking from the side. Parts of it do look well defined and somewhat smooth, but I would argue that part of this is irregular. Down here, less corticated, still somewhat well defined, but maybe you're starting to see some of the trabecular pattern where you get individual spindles of trabeculation left behind, which I said was a sign of malignancy. And then the giveaway here is this black arrow. We see proximal up the canal along the superior border, so closer to the origin of that canal, is this irregular, still well defined, but it's an irregular erosion along the superior border. And this is perineural spread, showing that, okay, what likes to do perineural spread? Malignancies. And so bad signs in this case, even though some of it look well defined and might make you first start thinking it's a benign thing, look for these other signs. Look for that ragged border. Look how destructive it is. If this were some large cyst, you'd expect it to be more kind of sac-shaped and just have that nice smooth cortex around it. This is an image I just showed you, just blown up now, showing that ragged border, those trabeculation left behind, moth-eaten appearance you could call this. All these things should lead you toward thinking malignancy. And so what's the differential diagnosis for squamous cell carcinoma? All those were cases of squamous cell carcinoma, by the way. In most cases, probably 99% of cases of squamous cell carcinoma, it arises from the soft tissue and then erodes into the bone. I think next we're going to get into that it can arise from little epithelial remnants, usually of dental tissues, if it arises from within the bone, but that's a lot more rare. Okay, so from the soft tissue into bone, osteomyelitis. This is pretty rare. Look, if you see something you're pretty sure are sequestra, especially when it has that chronic appearance, where you have those really dense sequestrations, that's more your osteomyelitis, more your chronic osteomyelitis. What we're describing here is squamous cell carcinoma may have that ragged appearance, and in some cases those spindles of trabeculation left behind might look like sequestra. But in my mind, it's pretty easy to distinguish a real osteomyelitis sequestrum from what we're talking about here. More invasive, destructive. Whenever something just behaves really aggressively and destructive, you want to start thinking malignancy. And then this is a key here. No periosteal bone reaction in squamous cell carcinoma. So your typical carcinoma or your typical malignancy of the mouth is not going to cause that periosteal bone reaction. Osteoradionecrosis, that would be similar to osteomyelitis, but you're going to just compare to the history. What's osteoradionecrosis? The patient has a history of radiation therapy, something with a very high dose of radiation. There is no amount of diagnostic radiation that's going to cause osteoradionecrosis, especially in the dental world, but even when we're talking about CTs, MRI has no ionizing radiation. And so it's a history of a previous malignancy that was treated with radiation therapy. Those are very high doses of radiation that can potentially cause new malignancies. But the trade-off, of course, is they need to treat the malignancy at hand. Okay, as promised here, I said in some cases, maybe 1%, I don't know the exact number, but a small number of cases of squamous cell carcinoma that could arise within bone. Typically remnants of a odontogenic epithelium. So as we see here, it's pretty close to the odontogenic region. And so there can be epithelial cells left behind that can turn into a squamous cell carcinoma. But other than arising from within the bone, everything else is the same as what we just talked about with squamous cell carcinoma, more common in the mandible than the maxilla, tooth-bearing regions, ragged borders. This looks somewhat smooth and round and well-defined, but if you look closely, it has little ragged moth-eaten borders. And so that's a bad sign. In rare cases, squamous cell carcinoma can arise within a cyst. This is really rare. Patients got to hit the unlucky lottery to get something like this. But cysts have epithelial cells. They can degenerate into a malignancy. So what are the properties we see here? I would call this irregular, moth-eaten. Looks like maybe a dentigerous cyst. Or it could be an OKC, another type of cystic type of lesion. But it's really lost that corticated border around here. So either very severely secondarily infected, or this might be turning into a malignancy. I already showed you one example of a panoramic radiograph where the sinus borders went missing, and I said that should be, red flag in your mind. Sinus border missing on one side, not the other. You have to think, what's destroying that? Is there some well-defined, smooth-bordered corticated lesion doing it? Or is it ill-defined, or in this case, more ragged? Although if you look very closely at the bone here, I think the malignancy has destroyed a lot of the bone, eaten into the marrow space here. So I would call this ill-defined. Definitely I would call it ragged. I would call this teeth floating in air, but does it look like your typical periodontitis? Hopefully you recognize it does not. Here's a cone beam CT of the same case. We really have the teeth floating in air. This looks so much like a case that I saw where the dentist did not diagnose it because they didn't know how to diagnose cone beam CT. And it was really sad because it should have been treated a lot earlier in the patient's life, but within just a couple of months, it had expanded all the way up into the patient's orbit. Very poor treatment, I think. It just goes to show that was a case that really shows how necessary it is to thoroughly investigate all your radiographs, and especially in cone beam CT where you have that 3D view, where you see so many more structures than you do even in pano. Although I pointed out all the different anatomical structures that are very clear in a panoramic radiograph, cone beam CT probably 10 times the number of structures. You're looking now at the skull base. The floor of the skull has so many foramina, all the way back into the nasal cavity, all the paranasal sinuses, not just the floor and posterior border of the maxillary sinus. But there's so much more responsibility that comes with that with 3D imaging. Here's another case. Here we see the floor of the sinus, but now we kind of have a floor of sinus floating in air. But we have an ill-defined destructive of the entire maxilla here. The posterior border of the sinus is destroyed. Where's my favorite anatomical structure on that side? And if you don't know what my favorite anatomical structure is, go back to my anatomy lectures. Something definitely to recognize. Zygomatic process of the maxilla. Why is that my favorite? Well, if you can distinguish that, you can distinguish it from the floors of the maxillary sinuses and recognize when one or the other is missing, which could be a sign, as is in this case, that you have a malignancy. So these are squamous cell carcinoma arising in the maxillary sinuses, certain risk factors, but I would say be able to identify these radiographically. All right, fibrosarcoma, if you look at this panoramic radiograph, basically it looks really similar to what we just showed you with squamous cell carcinoma arising in the sinus. Nothing necessarily radiographically jumps out to me and says this is a fibrosarcoma and not some carcinoma that arose in the sinus. We have your ill-defined borders, just very destructive. If they had teeth here, maybe the bone's been destroyed so much that they're just falling out at this point, but you might have that tooth floating in air appearance. Fibrosarcoma, a little bit younger, this peak prevalence compared to your carcinomas, your squamous cell carcinoma. So peaks in the 4th decade, meaning in the 30s, if you didn't get that. An enlarging mass can cause pain, as you would expect with malignancy. Typically what I do here is on these slides, I'll highlight in yellow text things that stand out from your typical malignancy. So we went through signs of typical malignancy, and we already said pain, paresthesia, that's common with malignancy. And so yellow is things that I think are more specific to whatever lesion we're looking at the moment. So growing along the bone and through the marrow space, All right, but as I said, there's nothing super distinguishing about this radiographically from carcinoma, from multiple other types of malignancy. So mainly be able to recognize the really destructive pattern of this and the ill-defined nature. What else is it destroyed? Floor of the sinus I mentioned. My favorite structure, again, zygomatic process of the maxilla. In fact, you don't see the zygoma at all. Here you see the zygoma and the zygomatic arch extending back here. That's all destroyed here. So that entire side of the face has just been completely destroyed. All right, radiographically, the appearance very similar to other central malignancies. So you're going to have on your differential, is it a metastasis? Do they have some other prior known malignancy? Myeloma, intraosseous carcinoma, or basically any type of lesion. Fibrosarcoma, other sarcomas, especially osteosarcoma, chondrosarcoma, those can be more of an enlarging bone, where it really tends to enlarge and grow the bone outward. So sarcomas can do that rather than just being completely destructive. All right, let's talk a little bit about metastatic tumors. I'll give you this great acronym for memorizing the most common primary malignancies to metastasize to the jaws. And that's down here, BLT kosher pickle, BLT-KP. So breast, lung, as you look at the percentages here, we've already covered almost half. Thyroid, kidneys actually higher, and prostate. I think that's our BLT kosher pickle, and that covers about 90% or more of the metastases to the jaw. If you want to go on, you can remember rectum and stomach, melanoma. But that pretty much covers the big ones, the more common ones that tend to metastasize to the jaws. Actually happens more commonly in females, likely because breast is so common. Breast cancer, 31% of all metastases to the jaw. As expected, as with any malignancy, it'll cause pain and paresthesia, can tend to destroy the hard palate, invade the PDL space, as I've shown with other malignancies before. In some cases, they aggregate at the apices of teeth and can mimic periapical radiolucencies. A lot of times, metastatic tumors are well-defined, but non-corticated. So I think of your typical punched-out appearance, your typical multiple myeloma. And these two are the ones to remember as ones that can stimulate bone formation, so they can appear radiopaque. So if it's radiopaque and ill-defined, and that's another lecture that I'll get to in a little bit, with ill-defined radiopaque lesions, mostly we're focusing on ill-defined radiolucent lesions. But while we're talking about metastases, you should know breast and prostate. So the two gender-specific ones, those are the two that cause opacities as they metastasize into the jaws and other areas. So patchy sclerosis, sometimes the spindle, the sun ray periosteal reaction can be caused by these as well. All right, so if you see something worrisome like this, where it looks like it could be metastatic tumor, specifically if you have a multifocal type of lesion, usually you're not going to get your first primary malignancy appear in two sides of the jaw at once, right? And so if you see that and it has malignant appearances, you're going to start thinking metastases. If the primary is known, usually it's pretty straightforward, particularly if you have a radiopaque one. What's it going to be? Well, if it's a male, it's going to be prostate metastasis, female going to be breast cancer metastasis.